So we're looking at the major histocompatibility complex 1 and 2. Okay, so the MHCs, that stands for major histocompatibility complex. They are coded for by the HLA genes. Okay, coded for by HLA genes. And what's their major function? They present antigens to T cells, right? Present antigens to T cells and bind. How do they present the antigens to T cell? By binding to T cell receptors, right? So that's how. And what's their main function? Besides presenting antigens to T cell, they're also involved in organ or transplant rejection. That's the other thing you know. MHCs, besides being involved in the immune response, are involved in transplant rejection. So that's the other part you'll see them. And there are two main types of MHCs. There's the MHC I, right, and the MHC II. MHC I, MHC II. So the most important things you need to note about this is MHC I coded by one letter. So you can see MHC I, that's HLA. So HLA, MHC. HLA is the gene that codes for MHC. So HLA A, B, C. So one letter. MHC I coded by HLA A, B, C. So one letters. All right. While MHC II, two letters. So HLA DP, DQ, DR. Very important. So two letters. The second thing you need to know about the difference between the two of them is MHC I presents antigens to CD4. MHC I presents antigens to CD8 T cells, right? While MHC II presents antigens to CD4, right? CD4. Other thing is the structure here. So looking at the structure here, right, you can see that MHC II has two equal sides. MHC II, two equal sides. So two alpha, two beta. So two alpha chains, two beta chains, right? Two alpha chains, two beta chains. That's alpha 1, alpha 2, right? And beta 1, beta 2. So two alpha chains, two beta chains. So MHC II, two equal sides, right? You can see it's two equal sides, two alpha, two beta, two equal sides, two parts to it, right? Then looking at MHC I has a long chain, a long alpha chain, and then a smaller chain here, beta 2 microglobulin, right? You can see beta 2 microglobulin. So a long alpha chain and a short beta 2 microglobulin chain, all right? So that's the main thing you need to know. So one long chain, one short chain. The long chain is the alpha chain. The short chain is the beta 2 microglobulin, while MHC II, two parts, two alpha, two beta, all right? Then MHC I presents antigens to all nucleated cells, all nucleated except red blood cells, right? So MHC is on all nucleated cell. MHC I on all nucleated cell. Very important. All nucleated cell except red blood cell. While MHC II is on only a few group of cells. That's APC, antigen present cells. And we say the antigen present cells are the macrophages, right? The dendritic cells, the Langerhans cells, and the B cells, right? So those are only cells that have MHC II. But that means, in addition to that, APCs also have MHC I, right? So they have both MHC I and MHC II on their surface. And they are the only cells that have MHC II. So you need to know that very important distinction. APCs have only MHC II, have both MHC I and MHC II on their surfaces. But they are the only group of cells that have MHC II on their surface. Every other cell in the body has, except red blood cell, has MHC I, not MHC II. Okay, so that's very important distinction there. Okay, then how are the antigens processed? So MHC I presents endogenous antigens. That's antigens that are generated within the cell. So you have the cell that has the MHC I, the antigen that will be presented on top of the MHC I are generated from within the cell. That's why they call it endogenous. And what are those type of antigens? Viral or proteins, viral and cytosolic protein. All right. While MHC II presents antigens that the cell will take from outside its environment, exogenous antigens, process it, and then present it on its surface to CD4 helper cells. So the antigen presented on MHC I is recognized by CD8 cells. Why that on MHC2, right, by CD4 positive cells? So let me show you an image of that, right? So this is how the antigen is very important for you to notice. So this is MHC1, how the antigen is processed for MHC1, right? So look at this. Look at this structure here. So you can see this is the cell membrane. This is the outside of the cell. This is the inside of the cell, right? So when the cell produces a protein, either a viral protein or a cytosolic protein, look at the proteins here. So that protein is first broken down by an organelle in the cell called proteasome. So once it's digested into tiny peptides, can I see here? Those peptides now enter the endoplasmic reticulum, which is here, right? And how do they get into the endoplasmic reticulum? Very important for you to notice this. They get in using this protein called TAP, all right? This protein called TAP, very important, all right? So this protein, this is a pump or a channel that allows the cytosolic proteins to enter the endoplasmic reticulum so that they can now sit on top of the MHC1. Look at the MHC1 that is manufactured inside the endoplasmic reticulum. The TAP will allow the cytosolic proteins coming through here inside into the endoplasmic reticulum, sit on top of the MHC, and then both protein and MHC will go to the cell surface and will be recognized by the CD8 T cell, which is outside there. So see the T cell receptor here, see the MHC1 with the peptide inside it. So very important for you to know this. So the proteasome, the protein broken down by proteasome, that peptides enter the endoplasmic reticulum via TAP, and once in the endoplasmic reticulum, bind to MHC1, and then go, the MHC1 and the protein will go to the cell surface for CD8 to bind them, all right? Then let's look at MHC2. How are the antigens presented? So antigens, how are the antigens presented in MHC2? So the antigens are loaded. So what we talked about for MHC1, this is it. Antigen peptides loaded onto MHC1 in the rough endoplasmic reticulum, which is delivered via TAP, that's transporter associated with antigen processing. That TAP that we looked at for MHC1. So very important for you to know about this protein and that it's associated with MHC1. Now let's looking at MHC2. How is it loaded? How is the antigen loaded onto MHC2 molecule inside the cell? So the antigen, once it's ingested into the cell, will be loaded onto the MHC2 after the release of the invariant chain in acidified endosome. All right, so let's look at how that happens. All right, so going back to this is for MHC2. So they're talking about how antigens come into the cell. Look at it, the endogenous antigen here, right? Look at your endogenous antigen outside here, right? So it's ingested into the cell, all right, and then forms the endosome. So this endosome is combined with a lysosome and then it's digested, broken up into pieces, all right? And then see your MHC2 is manufactured by the rough endoplasmic reticulum. And then once that happens, it gets to the lysosome here. So the endosome will combine with the lysosome, all right? And so once it's there, the MHC2 will come there as well. And then the peptides, you can see bits of them here, tiny bits of the peptide, all right? Once the peptides here are broken down, all right, then they will be loaded onto the MHC2. Look at the MHC2. So MHC2 comes from the endoplasmic reticulum to the lysosome there. And once there's a clip, look at this clip. This clip is uncovering the surface of the MHC2. So it has to be removed before the antigen can be loaded on top of it, right? And once those two, the antigen and the that's the invariant chain that first aid is talking about, the invariant chain removed from the surface of MHC2, and then the antigen will be loaded on top of MHC2, and then that will be transported to the surface for CD8 T cells to bind to it, right? So very important there. Okay, so moving on to that. So note that the associated proteins, beta-2 microglobulin in MHC1, and then invariant chain. It's not shown here, but this is the invariant chain that they are talking about. This chain, this clip is the invariant chain, that first aid is talking about, right? That is on top of the MHC2. All right, so this is the structure of it. Also very important for you to notice that structure. So we said MHC2, two halves, alpha, two alpha, two beta, equal halves, right? While MHC1, one long chain, one small chain, one long alpha, one short beta, two microglobulin. Now, next in this table, looking at this table here, right? So you note that there are some certain autoimmune disorders. So almost everything here are autoimmune. Not everything, but most diseases here are autoimmune associated with HLA subtypes. So if you notice this first part of the table here, this is MHC1 because it's one letter, BB, all right? And then the one at the bottom here, the last three are MHC2 because you see two letters, DQ, DR, DR, right? So those are associated with MHC2. Also very important for you to know that the disorders are associated with MHC1. So for B, for B27, right, these organisms, these disorders are called PAIR. So this is psoriatic arthritis, ankylosing spondylitis, all right, inflammatory bowel disease associated arthritis, and reactive arthritis, all right. So I'll just look at them, a few of them very quickly. So they are all called seronegative spondyloarthritis. That's what this group of disorders called, seronegative spondyloarthritis. So what you see in reactive arthritis, for example, you will see it's a combination of what they think of the mnemonic: can't see, can't pee, can't climb a tree. Can't see, can't pee, can't climb a tree. So can't see, conjunctivitis, uveitis. So we're talking of reactive conjunctivitis, uveitis. Can't pee, urethritis, right? Dysuria with pyuria. Then can't climb a tree. That's arthritis, right? So the lower limbs especially, right? So that's a reactive arthritis. Then for ankylosing spondylitis, think of it in a young. Before I move on, what kind of infections trigger reactive arthritis? GI infections, GU infections, right? So chlamydia for GU, chlamydia trachomatis; for GI, Shigella, Salmonella, Yersinia, and the others, right? So these things happen. The reactive happens after GI or GU infection. Then ankylosing spondylitis. Think of a young man who will have back pain, lower back pain, and the pain tends to improve with movement. All right, so that's ankylosing spondylitis. And then the spine, it tends to affect the lower back, the spine particularly. So if it continues for a long time, it will affect the way the spine will look on X-ray. So let me show you how it looks. Uh, so let me sorry. So this is the normal spine. All right, this is a normal spine in an adult. You can see everything, the spaces in between the vertebrae, right? And this is the spine that you will see in a patient with reactive as ankylosing spondylitis. So this is called bamboo spine. So you can see the spines are fused together. The vertebrae rather are fused together, looking like a bamboo. So look at it. This is normal. This is abnormal. So they can give you an X-ray of this and ask you what's going on here. And they talk about the man with a, a back pain that is worse, with chronic back pain, limited movement of the chest, even eye inflammation, that's uveitis, for example. So we just need to remember that. Okay, so moving on to the next one, that's abacavir. All right, so abacavir is an antiretroviral agent. So you have a history of a patient who probably has antiretroviral retroviral disease patient who's now started on a new drug, antiretroviral, and then he now comes down with severe skin rash, right? Rashes that involve the skin. So you take care of abacavir and know that it's associated with this HLA B57, all right? So very important to remember there. And then the next thing one I'll talk about, maybe I'll mention Graves and Hashimoto. So for Graves is an autoimmune disorder where you have antibodies that are attacking the thyroid gland, and they are overstimulating the thyroid gland, causing it to produce a lot of thyroid hormones, which leads to symptoms of hyperthyroidism. All right. In Hashimoto's thyroiditis, you have the immune system attacking the thyroid gland, destroying it. So that will lead to more features of hypothyroidism, right? Hypothyroidism. Then Addison's disease, you have problems with the adrenals, right? The adrenal glands, which are affected there. So that particularly to lead to problems with. So you see a young patient who is autoimmune, but in the Western world is autoimmune. In developing parts of the world, TB is the most likely cause. So it will lead to decreased production of a lot of hormone, that's cortisol and other hormones produced by the adrenal gland, and then increase because the adrenal gland is not working. ACTH from the brain will go up, all right. And so, what kind of patient will you have? Hypotension because of decreased testosterone, hyperpigmentation from increased ACTH, all right, and electrolyte abnormalities like hyperkalemia, that's increased calcium in the blood, all right, increased potassium rather, decreased sodium, okay, and metabolic acidosis, for example. So you have a patient with nausea, vomiting, weakness, and all of that, and you see increase the eosinophils too. So once you see patient vague symptoms, electrolyte abnormalities, increased eosinophils, start thinking about that Addison's disease. Then for rheumatoid arthritis, right? Rheumatoid arthritis, you think of patient with uh, is due to, you here you have the rheumatoid factor, right? The rheumatoid factor, which is an IgM attacking, right? Attacking the IgG to form. So the IgM binds to IgG, attacks the IgM, binds to it. So that's the rheumatoid factor. Another antibody that auto antibodies you have is anti cyclic citrullinated protein, anti-CCP, right? And then you also have elevated ESR and as well. So some of the symptoms you have is fever, fatigue, and all the rest, but then more of joint stiffness, right? Joint stiffness that is worse in the morning. So that's morning, and it affects both joints, joints in the hands, the wrist, symmetrically, right? So it can lead to joint deformities as well. So okay, I think that's that for that. So let's move on to